Recording in Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Namo Buddhaya, salam kebajikan. Yang terhormat Bapak Budi Gunadi Sadikin, Menteri Kesehatan Republik Indonesia. Yang terhormat Dr. Maria Endang Sumiwi, MPH, Direktur Jenderal Kesehatan Masyarakat Kementerian Kesehatan Republik Indonesia. Yang terhormat Dr. Lovely Daisy, MKM, Direktur Gizi dan Kesehatan Ibu dan Anak Kementerian Kesehatan Republik Indonesia. The Honorable Professor John Fair Shanoin, President of Global Pediatric Endocrinology and Diabetes. The Honorable Professor Paul Hofman, our guest speaker for this webinar. Yang terhormat Profesor Dr. Aman Pulungan, Spesialis Anak Konsultan FAAP FRCPI HON, Executive Director International Pediatric Association, narasumber dan inisiator dari webinar kami hari ini. Yang terhormat Dr. Agustini Utari, Spesialis Anak Konsultan MbChB, Vice President of Global Pediatric Endocrinology and Diabetes. Yang terhormat Dr. Muhammad Faizi, Spesialis Anak Konsultan, Ketua UKK Endocrinology Ikatan Dokter Anak Indonesia. Dan tentunya kepada seluruh peserta, selamat datang di webinar mengatasi masalah umum pada screening hipotiroid kongenital di Indonesia. Perkenalkan, saya Helena Arneta Putri yang akan berperan sebagai MC pada webinar hari ini. Webinar ini merupakan kolaborasi antara Global Pediatric Endocrinology and Diabetes atau GPED dan UKK Endocrinology Ikatan Dokter Anak Indonesia. Berikut kami lampirkan rundown dari webinar hari ini. Demi kelancaran acara hari ini, mohon diperhatikan peraturan dan ketentuan webinar yang telah dikirimkan melalui kolom chat. Tanpa menunggu lebih lama lagi, izinkan saya untuk mengundang pembicara pertama, yaitu Profesor Jean-Pierre Chanoin, MD, PhD, FRCPC Academic, as the President of Global Pediatric Endocrinology and Diabetes to deliver his opening address. Without further ado, to Professor Jean-Pierre Chanoin, the time and place is yours.
Good evening, everybody, and my name is Jean-Pierre Chanoin. I'm a pediatric endocrinologist from Vancouver, from Canada. Thank you so much for inviting me to give this introduction, and thank you to Arnetta, who has been really working very, very hard for this symposium that has attracted more than 1,500 people. So this is really a very, very big effort that is reflecting the importance of congenital hypothyroidism screening in Indonesia. This is a collaboration between the Indonesian Pediatric Society and Dr. Faizi, as well as Global Pediatric Endocrinology, GPED. And I'm going to give you a 2-second introduction on GPED, which is a professional organization, international, that has the goal to support clinical care, access to medicine, training in countries where the access to care is not so easy. And this is an organization that includes presently more than 400 members there. Congenital hypothyroidism screening is really something extremely important. Now, I will tell you a secret, is that it actually started in Canada. The very, very first screening was designed by a man named Jean Dussault in Canada, and this is where it all started from more than 40 years ago. So we have talked about the efforts by Professor Aman Pulungan, the importance of this meeting reflected by the presence of the Minister of Health, and we are, as we speak, screening more than 20 or 30,000 babies in Indonesia every week, and this is increasing very, very fast. This is an important screening. This is a screening that allows us to treat babies very early on in life and to prevent severe complications, severe irreversible complications on brain development. So without further ado, I will finish my talk there, and I want to thank really all the speakers in advance for this important contribution. Thank you.
Thank you very much, Professor Jean-Pierre Chanoin, for your kind welcome, as well as initiating this webinar collaboration with Indonesia. Kami akan lanjut selanjutnya dengan sesi berikutnya, yaitu keynote speech dari Bapak Budi Gunadi Sadikin sebagai Menteri Kesehatan Republik Indonesia. Kepada Bapak Menteri Kesehatan, waktu dan tempat kami persilahkan.
Okay, finally I can be unmuted. So, ladies and gentlemen, good afternoon. It is a great honor for me to be delivering my message to this seminar. First, I would like to thank Papa Aman Pulungan, because Papa Aman Pulungan is the one that convinced me that we need this newborn screening. I'm not a medical doctor, and I don't have any single medical background. So when I joined, my job is actually to execute the vaccination and control the pandemic. And I only have like 2 years left after the pandemic is under control to do the last task given by my president, which is to do the biggest major reform in Indonesian healthcare sector. So I'm start working on with key professionals like Pak Aman. What should I do? And just realized that Indonesia has not started the newborn screening ever, which is I'm very surprised. So there is no national newborn screening program mandated by the Indonesian government. If I compare with other governments, like Korea, they do more than 50 tests for newborn screening. Singapore, Malaysia, even Vietnam is more advanced than Indonesia to do newborn screening. And Pak Aman Pulungan convinced me that it's a very important screening for the life of the baby, and also for the livelihood of the baby's school. So that's why we initiated the national newborn screening with first test, the congenital hypothyroidism. And it started this year. For your information, we did pilot project of the CHT since several years back, but the result is only 100,000 babies out of 4.8 million annual babies delivery that have been tested. So again, I want to reiterate, Indonesia have 4.8 million babies every year, almost similar with the population of Singapore, which is 5 million. So we have one Singapore every year, babies there. And only 100,000, so less around 3% is what are tested. So can you imagine, we are lack of testing, and those babies, are very prone to get this disease, but can be treated. So that's why this year we embarked into this national initiative. And so far, I can tell you, I'm quite happy. I'm not really happy because I monitor on weekly basis. We equip all the labs, increase from 2 to I think now it's more than 11 labs. We provide the financing. We also launched the program nationally. And, so far we have increased from 100,000 tests last year to around, 400, 500 tests until now. So maybe until the end of this year, we can get into 600,000, 700,000 tests. I'm happy in the sense that we have increased 400 times or 4-fold in terms of testing. But I'm personally is not yet happy because my expectation, at least we go from 100,000 to 2.5 million. So 50% of the babies. And I keep encouraging the team, let's move faster, let's work harder and save those babies. If we can do 20,000 a week, actually we have to have ambition to at least reach 50,000 a week. Maybe at the end of this year or at the end of this quarter. But we need to have a great ambition because we are lag behind. And next year, I would like to increase the newborn testing with congenital adrenal hyperplasia and also G6PD. So hopefully when I retire in 2024, in the newborn screening arena, I've successfully started the CHT, CAH, and also the G6PD. And I would like to do it in a massive scale because we have 4.8 million babies every year. I have to thank Prof. Aman for your commitment and your support and your passion to make things happen. And I need you to keep your enthusiasm and let's push it faster, push it bigger, and save our baby. You know, in Confucius, there is a saying: if you want to be prosper in a year, you grow rice. But if you want to be prosperous for 10 years, you grow tree. If you want to prosperous 100 years and more, you grow people. So I think if Indonesia would like to become a prosperous country, a prosperous nation, we have to grow and protect our baby. So at least 2.5 million of our babies got tested every year and gradually increase to 100% in the next 5 years, at least on those 3 basic testing. Again, congratulations. Thanks to all of you, and have a nice day. Thank you.
Terima kasih banyak Bapak Menteri Kesehatan atas keynote speech-nya. Selanjutnya kita akan ada sesi berfoto bersama dengan Bapak Menteri Kesehatan serta semua para tamu undangan kami. Dengan itu kami mengundang Dr. Maria Enang Sumiwi, MPH Direktur Jenderal Kesehatan Masyarakat Kementerian Kesehatan Republik Indonesia, Dr. Lovely Daisy, MKM Direktur Gizi dan Kesehatan Ibu dan Anak Kementerian Kesehatan Republik Indonesia, and of course to Professor Jean-Pierre Chanoin, Professor Paul Hofman, Professor Aman Pulungan, Dr. Agustini Utari, and Dr. Muhammad Faizi. We invite you all to the screen. So we will be waiting for Professor Paul Hofman to join us as well. So I'll be taking the photo now. 3, 2, 1. 3, 2, 1. 3, 2, 1. Okay, we will be taking more pictures with the participants. So if the participants would like to turn their videos on. 3, 2, 1. 3, 2, 1. 3, 2, 1. That concludes our photo session for today.
Ya, makasih Pak Menteri.
Sekali lagi kami mewakili panitia, kami ucapkan terima kasih yang sebesar-besarnya kepada Bapak Menteri Kesehatan Republik Indonesia serta para tamu undangan yang kami hormati. Selanjutnya, kami akan lanjut ke acara selanjutnya yang akan dipandu oleh moderator webinar hari ini. Izinkan saya untuk memperkenalkan moderator untuk webinar kita hari ini. Dr. Muhammad Faizi, spesialis anak konsultan, merupakan Ketua UKK Endokrinologi Ikatan Dokter Anak Indonesia. Beliau menyelesaikan pendidikan dokter di Universitas Erlangga pada tahun 1989, pendidikan dokter spesialis anak di Universitas Erlangga pada tahun 1999, dan telah menempuh berbagai training dan fellowship di bidang endokrinologi anak di Indonesia, Singapura, dan Jepang, serta pendidikan PhD di Universitas Erlangga pada tahun 2022. Saat ini, beliau juga merupakan faculty member di Departemen Ilmu Kesehatan Anak Fakultas Kedokteran Universitas Erlangga. Tanpa menunggu lebih lama lagi, kepada Dr. Faizi, waktu dan tempat saya persilahkan.
Terima kasih Agatha atas kenalannya. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore, Bapak Ibu, Profesor, Dokter, peserta, dan para tamu undangan sekalian. Perkenalkan saya Muhammad Faizi yang telah diperkenalkan oleh MbChB untuk memimpin acara sesi materi. Ada 2 materi. Yang pertama akan disampaikan oleh Profesor Dr. Aman Pulungan, dan yang kedua adalah Profesor Paul Hofman. Selanjutnya, saat ini akan disampaikan materi tentang screening hipothyroid kongenital di Indonesia, kemajuan dan tantangannya. Saya izin memperkenalkan Prof. Aman, walaupun mungkin sebagian besar dari kita sudah mengenal beliau secara luas. Beliau adalah seorang guru besar dari Fakultas Kedokteran Universitas Erlangga dan project leader dari CDIC, ini bidang diabetes anak. Beliau juga mantan Ketua Ikatan Dokter Indonesia, mantan Presiden Asia Pacific Pediatric Association, APES, ya, dan banyak sekali karir beliau, baik nasional maupun internasional. Dan beliau sudah menerbitkan lebih dari 100 artikel ilmiah di berbagai jurnal dan buku. Silakan Prof. Aman untuk menyampaikan.
Terima kasih Dr. Faizi. Slide saya oke ya?
Baik Prof, baik.
Oke. Sorry, Paul and JP, I have to present in bahasa ya, and also my presentation would be in bahasa ya. Oke. Jadi selamat sore semuanya. Assalamualaikum warahmatullahi wabarakatuh. Terima kasih juga dan ya terima kasih diberikan kepercayaan untuk sharing bagaimana keadaan ya. Saya sapa juga Bu Dirjen dan Bu Direktur ya yang hadir pada saat ini ya. Sebentar. Kok kenapa tidak bisa ini? Oke. Bahasannya adalah mengenai progres dan tantangan ya. Jadi yang kita bahas nanti bagaimana screening, apa hipotiroid kongenital, tantangannya dan kesimpulan. Jadi saya akan bahas juga nanti mungkin overlapping dengan Profesor Paul. Contoh kasus seperti ini dari Makassar ya. Jadi ketika dia di screening, ya spontan cukup bulan, lahir, ya 1 jam setelah lahir langsung di screening. Nanti kita lihat bagaimana harusnya keputusan dari Kemenkes, anjurannya bagaimana. Hasilnya TSH-nya tinggi, di atas 20. Harus dikonfirmasi. Kalau di atas 20, ternyata dia normal. Jadi ini bayi bukan hipotiroid kongenital. Nah, kasus yang lain juga dari Sulawesi Tengah, ini baru, lahir 4.000, asfiksi, menangis ya. Dan di screening, umur 48 jam. Jadi betul ya, 48 sampai 72 jam, diambil dari tumit, hasilnya juga 23,7. Positif. Ketika dikonfirmasi, jelas kelihatan di sini FT4-nya dan TSH-nya normal. Jadi konfirmasi itu adalah sesuatu yang paling penting, apalagi pada saat keadaan bayi yang lagi sakit. Jadi harus dikonfirmasi. Tidak bisa diterapi hanya dengan TSH neonatus lebih dari 20. Semua kita ini targetnya untuk SDG 2030 ya. Jadi yang nomor 3 khususnya menjamin kehidupan yang sehat, meningkatkan kesejahteraan penduduk semua manusia, akses to medicine, akses testing, akses untuk screening. Semuanya ini masuk di sini. Nah, screening bayi baru lahir ini secara dini harus penting untuk mencegah komplikasi jangka panjang. Deteksi penyakit pada fase asimptomatik, panel screening bayi baru lahir tersedia secara luas di negara maju, bahkan bisa puluhan bahkan ratusan. Kita lihat di sini Indonesia, data dari global health ini kita masih sedikit sekali dibanding negara-negara lain. Ya, kita masuk yang sedikit. Tetapi pada saat pandemi, semua negara ini terganggu. Nanti kita lihat bagaimana kita dari yang sedikit hampir tidak ada, from nothing, kita bisa menjadi 23.000. Komponennya apa yang paling penting? Newborn screening, edukasi, ini yang kita lakukan. Screening harus dilakukan, diagnosis, tata laksana, follow up, dan evaluasi. Tetapi ini harus terintegrasi, diimplementasikan pada program. Tentulah ada aspek ekonomi, aspek politik, sosial, dan budaya. Hipotiroid kongenital, saya coba ingatkan lagi, mungkin semua masih ingat, ada yang tersier, primer, dan sekunder ya. Jadi dari hipotalamus ada thyroid releasing hormone, TSH, T3, dan T4 ya. Inilah aksis tiroid kita lihat. Nah, sebetulnya T4 ini yang terikat itu dengan TBG 70%. Ya. Nah, yang bentuk bebas ini sebetulnya sedikit, tetapi inilah yang kita perlukan dan yang kita tes. Jadi faktor yang mengaruhi TBG ini banyak. Ya, misalnya hepatitis ya, misalnya ada minum obat, bayinya dikasih fenobarbital, dikasih steroid dan lain-lain, malnutrisi dan dapat hormon estrogen. Nah, fungsi hormon tiroid, sebentar saya lihat ini. Oke. Nah, fungsi hormon tiroid ini kita lihat sebetulnya otak yang paling penting. Metabolisme, pertumbuhan tulang betul, ya, jantung juga, dan produksi eritrosit. Dan juga kalau pada saat dewasa nanti mempengaruhi fertilitas, ovulasi, dan menstruasi juga. Jadi kalau kita lihat, hormon tiroid ini membantu myelinisasi. Jadi dia ini membantu nerve conducting velocity. Ya. Jadi kalau misalnya pada anak yang hipotiroid, kita bicara kayak begini, ada waktu tenggang dia untuk menerima dan bisa budek akhirnya. Jadi seluruh saraf yang terkait myelinisasi di dalam tubuhnya itu, ini akan terganggu kalau dia hipotiroid. Jadi hang semuanya kan. Nah ini tidak boleh terjadi makanya. Epidemiologinya secara global 1 dari 2.000 sampai 4.000. Datanya memang laki-laki 2:1 dan meningkat pada anak dengan sindrom Down. Dan ini suatu penyakit yang retardasi mental yang paling umum yang bisa dicegah. Ya. Jadi apa yang harus kita laksanakan? Dan ini diperkenalkan tadi sebetulnya di Kanada, tadi seperti kata Dr. Jean-Pierre, penyebabnya bisa disgenesis, ya, bisa juga dishormogenesis, bisa yang endemik, juga bisa yang ektopik dan lain-lain. Kita lihat angka kejadiannya. Gejalanya, sebetulnya tadinya saya nggak mau masukkan slide ini, karena tidak boleh ada gejala sebetulnya. Tetapi karena kita negara yang belum ada screening, terpaksa saya kasih tahu bahwa adalah gejalanya seperti ini. Tidur berlebihan, aktivitas berkurang, hipotoni, nangisnya juga pelan, ya, kuning berkepanjangan, metabolismenya, suhunya dingin, konstipasi, hernia umbilikal, makroglosi lidahnya, dan yang paling bahaya adalah buruknya perkembangan otak. Baru dirilis nih 2022 akhir, bahwa di seluruh ASEAN, IQ Indonesia ini masuk yang paling rendah. Kita bahkan di bawah Laos, di bawah Filipina, di bawah Filipina. Rata-rata di bawah Vietnam, IQ kita ini. Nggak tahu apakah mungkin karena kita belum di screening, karena kita harusnya pintar-pintar semua kan. Nah, contohnya seperti ini. Kalau melihat bayi seperti ini, jangan lupa atau harus dipikirkan yang pertama kali ada hipothyroid kongenital. Ini khas sekali kan? Tapi harusnya kita tidak melihat seperti ini. Kebanyakan bayi dengan hipothyroid kongenital tidak terlihat sering. SHK dengan terapi tiroid dimulai usia 2 minggu. Ya, SHK dilanjutkan oleh terapi levotiroxin secara dini mencegah berbagai komplikasi kognitif, psikomotor, dan juga gangguan pertumbuhan. Nah, hipothyroid kongenital yang permanen ini bisa yang kena primer, disgenesis, ya, resisten TSH atau dishormogenesis, tapi yang transien juga ada. Tapi nantinya ini tentu dilihat dalam hal perkembangannya, perjalanan penyakitnya. Kasus pertama ini saya selalu sharing kasus ini ya, dari poliendokrin. Kita anak perempuan umur 6 tahun 10 bulan, ya, perawakan pendek, jelas mukanya seperti ini, lidah besar, hernia umbilikal. Coba lihat ST4, rendah sekali dan TSH-nya tinggi. Tapi yang paling menyedihkan, IQ-nya 37. Pernah tahu pasien kita IQ-nya 37? Nggak mungkin. Ini di terapi juga tidak akan naik IQ-nya. Jadi ini kenapa? Karena tidak di screening. Pasien tinggal di Jakarta. Ya. Jadi ini hipothyroid kongenital yang terapinya sangat murah dan sangat simpel, hanya diberikan levotiroxin. Ya. Simpel sekali. Sementara anak yang lain tinggal juga di Jakarta, umurnya hampir sama, IQ-nya sekarang 124. Ranking 3. Dan dia ini di screening sejak lahir. Pertumbuhannya juga tidak terganggu. Nggak fair ya. Lahir di kota yang sama, yang satu di screening, karena lahir di rumah sakit dia di screening, yang satu lagi lahir di rumah sakit yang tidak di screening. Ini salah siapa jadinya kalau saya bilang? Kita sebagai tenaga kesehatan, ini harus memastikan kalau melihat bayi di rumah sakit kita, ini di screening. Nah, masalahnya apa? Diagnosisnya terlambat. Yang anak perempuan akhirnya pendek dan IQ-nya rendah. Sementara anak laki-laki tadi bukan karena dia laki-laki, karena dia di screening. Kita lihat. Jadi keterlibatan sistem saraf pusat ini kita lihat. Ini datanya kita lihat. Rata-rata IQ-nya ini bisa 76. Kalau diobatin dan lain-lain seperti ini. Nah, tapi saya kasih tahu nanti data kita. Data saya sendiri itu ada yang IQ-nya di atas 90 walaupun telat. Harusnya mungkin IQ-nya 150 atau 140. Tapi karena hipothyroid dia hanya IQ-nya 90 dan 100. Nah, ini data saya sendiri, ini publikasinya ya. Tahun 2000 berapa nih? Cukup lama ya, 2019 sudah ya. Kalau kita lihat di sini, kita lihat 96% perkembangan terlambat, 72% disabilitas dan sebagian IQ-nya ini di bawah 70. Tapi ada di sini 2-3 orang kalau tidak salah itu IQ-nya di atas 90 atau 100 yang telat. Jadi berarti apa? Jadi berarti ini bisa kita lakukan. Ya. Nah, kita lihat di sini terapinya, ya, dan juga follow up-nya. Ya. Saya coba cepat ini ya. Nah, thyroid scan, follow up-nya juga apa yang harus dilakukan. Prognosisnya ini kita lihat yang ablasi buruk, Tapi kalau diobatin tidak, dan terapi ini harus dimulai tentu dengan prognosis yang baik. Screening ini kita lakukan, ya. Kita lihat screening hipotiroid, tingkat provinsi, komponennya ada, ya. Terus di negara semuanya di dunia dilakukan. Ini yang kita lakukan, preliminary data saya. Ya. Kita lihat di sini, ya. Sebentar, saya lihat tadi ini ada note saya buat saya apa nih ya? Sebentar. Oke, ya. Oh, nggak ada. Saya kira habis waktu saya. Oke. Nah, kita lihat di sini. Ternyata data kami ini, kita lihat ya di sini ada Dr. Frida, Dr. Agustini, Dr. Niken, Prof. Madarina juga ya, Dr. Diada, Atika, dan Dr. Bikin. Ini dari semua kota. Kita ini 1 dari 1.200. Data dunia 1 dari 4.000. Jadi berarti mungkin data kita itu lebih tinggi dari seluruh dunia kalau kita screening. Ya, jadi karena itu penting untuk meningkatkan kesadaran pada masyarakat dan mempertahankan kerjasama yang baik pada pelayanan kesehatan. Kita lihat sejarahnya ini ya, dari tahun 99. Jadi ada senior guru saya di sini, Dr. Dit mungkin ikut, beliaulah yang awal-awal mengadakan harus screening. Nah akhirnya kita lihat 2021 itu 2022 di relaunch ya, dan sekarang ini terbitlah keputusan Menteri 2023, pada saat itu hanya 2% yang di screening. Nah kita lihat sekarang ini, sekarang sudah 8,28%. 8,26% di Indonesia pada bulan Agustus. Tadi kata Bu Direktur, September ini nanti semuanya akan ditanggung, ini akan meningkat. Jadi kita bisa lihat peningkatannya pada negara lain pada pandemi dia turun, kita ini meningkat sekarang 20 atau 30 ribu per minggu. Tetapinya ada beberapa rumah sakit ini masih rendah sekali. Kita lihat ada Malik, Padang, ya. Kalau yang mana lagi kita rendah? Kita bisa lihat ini datanya yang kecil-kecil sekali cakupannya. Kita lihat yang di bawah 10% nih ya. Ya, Jabar juga, Bengkulu, Kalsel, Sumsel, Jatim, Sumbar, ya, Kalbar. Ya, kalau misalnya ini, kalau Papua oke lah. Sumut cuma 2,27% coba. Kalau ada yang dari Sumut di sini. Kenapa? Ya kan? Nanti orang Sumut bisa terganggu. Ininya. Semua ini kalau tidak di screening, yang siapa saja, bukan di Sumut saja ya, di mana saja ini anak-anak IQ-nya bisa turun kalau tidak di screening. Jadi cakupan ini kita sendiri yang harus juga ribut supaya ini naik. Karena dari pemerintah kan sudah ada. Nah, alurnya bagaimana? Kita lihat jelas di sini ya. Dari permintaan BHP-nya terus kita lakukan sampai kalau TSH normal, pemantauan tumbuh kembang di FKTP. TSH tinggi, tata laksana. Yang penting, ada yang nanya waktu itu, TSH tinggi bagaimana? Tidak perlu konfirmasi? Oh tidak. TSH tinggi harus dikonfirmasi. Tadi contoh 2 kasus di atas, lihat kan? Kalau kita terapi dia bagaimana kan? Nah kalau positif, tentulah tata laksana pengobatan. Kalau dia negatif, dipantau tetap seharusnya. Ya, ini ada keputusan menteri ya, dan pengambilannya kita lihat bayi umur 48. Kalau toh bayi ini terpaksa memang pulang, lakukanlah setelah umur 24 jam. Tapi ketika hasilnya positif harus dikonfirmasi. Diulang dan sebaiknya sampai umur 2 minggu. Bayi saat kritis dia diulang lagi atau prematur juga, nanti umur 2 minggu harus diulang. Nah, ini kita lihat FKTP merujuknya bagian tarifnya pergantian bagi peserta JKN tidak boleh dikenakan urun biaya. Rekomendasinya dari IDAI kita lihat di sini, ini yang bahkan 2017 sudah hampir sama, screening, TSH yang di atas 20, positif dikonfirmasi di terapi, diagnosisnya berdasarkan FT4 dan TSH. Tidak bisa satu saja, FT4 dan TSH. Ya. Nah, tata laksananya kita lihat di sini. Tantangannya apa kita lihat? Masyarakatnya, layanan kesehatan. Finansial sekarang kan dibantu pemerintah sudah. Manajemen data tracking system ini kita masih jelek. Tantangan geografis itu saya sepakat. Tapi mungkin kan kalau tantangan geografis di Sumut, Bengkulu, misalnya di Sumatera kan Jawa tidak ada tantangan geografis. Ya, kalau seperti ini kalau saya bilang, ini ada apa nih kalau saya lihat apanya? Oke, saya punya waktu 5 menit lagi, saya coba. kondisi ekonomi yang buruk, tantangan geografis, tingginya mortalitas ya. Nah, jumlah populasi yang tinggi ini juga kita, Indonesia tidak ada data, India, Filipina cukup datanya, terbatas laboratorium, tapi sekarang kita sudah punya 11-12 rujukan, bayi pulang lebih cepat, ini bisa kita atasi, fasilitas terapi dan biaya. Sulitnya political will, tapi kita sudah lihat, Pak Menkes mengatakan, political dari government, dukungan penuh dari pemerintah. Nanti kalau tidak, SDG tidak tercapai. Rendahnya kesadaran, nah ini, masyarakat ini harus kita katakan semua bayi harus di-screening. Screening harus terintegrasi. Ya. Nah, kita lihat juga apa yang perlu dilakukan. Meningkatkan kesadaran publik. Jadi seluruh peserta seminar ini, tolong tingkatkan semua kesadaran publik. Tenaga kesehatan, sistem nasional harus kita bangun. Cost benefit tentu. Dukungan pemerintah kita sudah dapat. Dukungan pemerintah, pembiayaan, dukungan partisipasi praktisi kesehatan, kita harus mendukung ini semua. Ya, ini harus dimulai sekarang. Evaluasi program secara rutin dan utuh, dan follow up diagnosis dan terapi ini penting. Ya, tantangan SHK rendahnya kesadaran dan edukasi. Jadi kalau semua orang tua meminta bayinya di screening apapun kejadian, ini akan terjadi. Ya, karena masalahnya masih ada tenaga kesehatan yang tidak mengharuskan ini. Menyedihkan kan? Tidak seimbangnya akses pelayanan kesehatan ini betul. Keterbatasan finansial pada keluarga, tapi sekarang sudah ditanggung oleh pemerintah. Infrastruktur, ini harus kita atasi. Terbatasnya pelatihan tenaga kesehatan, ini ongoing sudah dilakukan. Tadi Bu Dirjen juga mengatakan, budaya dan kepercayaan. Kalau ini pelan-pelan harus kita atasi. Buruknya manajemen data, ini bisa kita atasi. Koordinasi antar pemangku jabatan, ini juga harus kita atasi. Keputusan Menteri Kesehatan terkini dapat mendukung implementasi SHK di Indonesia. Jelas tadi Kepresnya yang 2023. Jadi semuanya di sini kita didukung secara penuh oleh pemerintah dengan keputusan Menteri Kesehatan. Meningkatkan screening hipothyroid kongenital, ya, melibatkan kolaboratif pemerintah, tenaga kesehatan, masyarakat, dan kelompok advokasi. Meningkatkan kesadaran, memperbaiki infrastruktur, menyediakan pelatihan, dan mengatasi tantangan budaya. Terima kasih, ya. Mudah-mudahan bermanfaat. Saya kembalikan ke Dr. Faizi. Terima kasih.
Terima kasih Prof. Aman atas presentasinya yang menarik. Selanjutnya kita laksanakan bahasa Inggris. The next presentation will be brought by Professor Hofman, MbChB, Dean of FRACP, with the title Practical Approach to Congenital Hypothyroidism, Newborn Screening, Opportunities and Challenges. I will introduce Professor Hofman. He is a pediatric endocrinologist and researcher based at Leiden Institute, University of Auckland. He has many papers that published in international journal, and he has been also as president of both Australian Pediatric Endocrine Society and Asia Pacific Pediatric Endocrine Society, and is involved in promoting endocrine training in Asia Pacific region, as well as improving pediatric endocrine care and results concerned countries in Asia Pacific region. Without further ado, to Professor Hofman, the time and place is yours.
Very much for the organizing committee for inviting me to speak today on a subject that is very dear to my heart. The title of my talk today is A Practical Approach to Congenital Hypothyroidism Newborn Screening, Opportunities and Challenges. And let's talk about hypothyroidism, congenital hypothyroidism. This is one of the most common preventable causes of irreversible intellectual disability that we know of, and probably second after iodine deficiency. It is also the most common congenital endocrine disorder. Thyroxine is essential for the development of normal neuronal networks, as I was saying earlier, and it's also important for the normal myelination of the brain, and these occur over the first 2 to 3 years postnatally. So this is the time you need a good thyroid hormone levels, normal thyroid hormone levels, not too high and not too low. What about before birth? If you're born without a thyroid gland or without a thyroid gland that is working effectively, what happens before birth? Well, enough thyroid hormone crosses from the mother to continue normal fetal central nervous system development, assuming, of course, that the mother does not have hypothyroidism due to iodine deficiency or another cause. So long as the mother's thyroid hormone levels are normal, the baby will be protected until birth, and it's then that the risk starts. Now, we know from a large number of studies that early postnatal replacement of thyroid hormone therapy can markedly improve and probably, I think now, normalize neurocognitive development. It's even true in those with transient hypothyroidism, and these are people who have abnormal thyroid function over the first months or year or so of life. And this is a critical time for neurodevelopment, and you need to have normal thyroid levels during this time. The therapy is effective and it's also cheap, which makes screening such a attractive opposition. If there is a delay in diagnosis, and that can happen whether you're screening or not, there is still a benefit to the child of starting even later. We know that there's a loss of around 2 to 5 IQ points per week of delayed diagnosis. So even the diagnosis delayed by a month or two, the child is likely to have a normal intellect, even if it's slightly reduced on what it was going to be. We know also that early inappropriate thyroid hormone replacement will prevent developmental delay. But one of the things that's really important to say to families, if you have a child or a family with a child with a positive screen, in other words, likely has congenital hypothyroidism, the one thing you do not want to say is that this child is going to be developmentally normal, because hypothyroidism can be associated with other neurological abnormalities, such as TTF1 defects, Williams syndrome, Albright's hereditary osteodystrophy. And it's also possible, because this is a relatively common condition, to be associated with other causes of developmental delay. So the one thing I say to families is that with early and aggressive treatment, these children will not have intellectual disability caused by their hypothyroidism, because I don't think we can say that these children will necessarily be normal, although the majority are. As mentioned above, the maternal thyroid and iodine status is important because that will impact on what happens before the baby is born. Interestingly, a Turkish study has confirmed this, really, showing that about 5% or 1 in 20 of the early diagnosed children in Turkey were moderately delayed, probably due to these other variables. Now, I think we all know and have all seen children with congenital hypothyroidism. And I know in countries which don't screen, as Indonesia has not until recently, these sites are relatively commonplace. But this is what we want to avoid. And even when you treat late, as this is an 11-year-old girl, you see dramatic changes with thyroid hormone therapy, and you can see even more changes, I think, in the baby underneath. So thyroid hormone works magically, but unfortunately, when you're older, you have ongoing developmental delay. And as you can see here from this data, if you look across the region, and probably in our region, China has the most complete data, we're looking at levels which are higher than most of the Western countries. And in some places, such as India, but I have to say this Indian data is on a very small population, the levels are actually quite high. So we're looking at numbers down to 1 in 800, but most of the studies would suggest somewhere between 1 in 1,500 to 1 in 2,000 is more the likely frequency of congenital hypothyroidism in your population. Time will tell, though, and when you have more data, you'll be able to accurately analyze this for yourselves. Okay, so we have this really awful condition that is imminently treatable, and we can prevent the neuropsychological sequelae if we treat the thyroid hormone early in life and over the first 3 years at least. So, should we screen for it? Well, when we look at screening, there are a number of factors we should be looking at. The first is that that there is an effective treatment available, which we have with congenital hypothyroidism. The second is that the disorder is sufficiently frequent to justify the cost of screening, and that's been clearly shown in multiple cost-effectiveness studies. The third is that there is an effective test to diagnose it, and indeed there is, and it's cheap, and it's reproducible and accurate. And the last is the disorder is likely to lead to significant morbidity or mortality and cost to society. And I think all of us would agree that congenital hypothyroidism will do that. And indeed, this is a quote for a recent current opinions article from the Philippines and from American authors, stated that congenital hypothyroidism is the most cost-effective screen condition in most countries, and I would completely concur with this. When we look at newborn screening in countries with limited resources, and the reality is most of us to some degree have limited resources, there is no textbook or guide to help. It's mainly common sense. We do know that there's a lack of screening across the Asia-Pacific region. We have over 50% of the world's children in the Asia-Pacific region, mainly in Asia, but 70% were not screened, at least until about 5 to 10 years ago. That is actually changing, but we've still got a substantial number, more than 50% not screened. In China, which is over 15 million children, that has almost completely got newborn screening now on all their children. In India, which is 24 million babies a year, they have got partial screening. Japan and Korea have got almost full screening, as has New Zealand and Australia. And Thailand and Philippines are doing a good job of getting over well over half their population screened now. Pakistan is still trying to increase theirs. But across the region, there are a large number of countries which are still not doing this, I think, very important public health measure. What do we require to establish and expand a screening program? Okay, so there are a number of key facets to doing this. The first is that you need local advocates, people who will drive the newborn screening forward, because this is hard to do. You need to have someone who is either a newborn screening expert or as well pediatricians who have got an interest in this area and who are willing to treat them when they get diagnosed. So you need a team of people who are committed to pushing newborn screening forward. You also need government input. Your Ministry of Health or your Department of Health needs to be involved. They need to have a financial long-term commitment, as well as providing other support as well. As part of that, it's useful to have a cost-effective analysis, which I understand has not been done in Indonesia, but it has been done in multiple areas of the world, in countries which are both rich and resource limited, and it is consistently cost-effective. So I think this is less of an issue. You need, very importantly, infrastructure to enable the blood test, the Guthrie cards or the filter paper cards to be taken. You need some way to get them to the lab and a system to do that effectively and quickly. And then you need to have laboratories situated so that they can do the testing, they can analyze the cards in a reasonably appropriate time frame, and then they have the ability to notify people and the capacity to follow up with repeat testing or referral to a pediatrician as required. And of course, from that perspective, you need pediatric expertise when patients need referring and where the patients are, so they can be assessed and treatment started as soon as possible. And of course, underlying all that, you actually need to have thyroid hormone available. And one of the nice things about thyroid hormone is it's cheap and it's generally readily available internationally. Okay, so what is the best newborn screening paradigm to use? And I don't think there is one. You've got to use what suits your local area and your local resources. You've got to look at how you're going to get those filter paper or Guthrie cards tested, who's doing it, who's responsible. Once they're done, how do you collect them all together and batch them and then send them off on a regular basis, probably every few days or once a week, depending how many you're doing. I know in Indonesia, you have a much more village-based midwife system as opposed to going to hospital. So this will have to be done more in a local situation and then sent to the laboratories. You have to have laboratory expertise and the capacity to do the testing. And of course, the country the size of Indonesia, that is a daunting process because it is a huge country. Once you've done that, once you've taken it to a lab, the lab have got to identify the positive results in a country of Indonesia size. You could be getting somewhere between 1,000 to 2,000 positive tests a year. They then need to somehow identify and notify the families, which can be hard. And then equally as hard, those families have then got to get to a centre where appropriate management can be undertaken. One of the things to remember about any screening test, and I do emphasise this to all the people I speak to, is that screening does not and will never catch everybody. In part, that reflects the cutoffs we use. The lower the cutoff, the more likely you are to get patients, but the lower the cutoff, the more likely you are to have a lot more work on people who don't need to be investigated. So choosing an appropriate cutoff is very important in terms of making your system efficient. But you can have mistakes in collection. They might have had a Guthrie card or a filter paper card done. The card may not have got to the laboratory. The laboratory may have messed up the test, or it may not have been done. And if they've been identified, there may be no way to get hold of the family. And if you get hold of the family may have had no way to get to someone who can treat them. So there are always a number of steps that can go wrong. But the reality is the idea with screening is to try and pick up as many people as possible. And that is, I think, the goal, rather than trying to identify everybody and treat everybody with congenital hypothyroidism. Although that, of course, is what we're always aiming for. In terms of the screening tool we use, TSH is a very cheap, cost-effective strategy that picks up all children who have primary hypothyroidism, in other words, a defect in the thyroid gland. That is the defect we know causes severe developmental delay. It will, however, not pick up pituitary or hypothalamic causes of hypothyroidism. Therefore, you have to have a high index of suspicion. If you think that there's prolonged jaundice or poor feeding or cold intolerance or hypoglycemia, you should always look at thyroid function tests. Right, timing of collections is an issue. It's an issue because in lots of places, people go to a hospital, give birth, then leave. And so if you're trying to get a level, ideally around 2 days of age, 48 hours of age, that is really hard. And so many countries in the world, and India is a classic one, but it's been used in other places such as Sri Lanka, a cord blood sample for TSH has been done. Now you have to look at higher levels, and I'll demonstrate why that is in a second, but it is a very effective strategy nonetheless. It makes it harder to do other newborn screening though. So if you're looking at other newborn screening tests the longer term, it's better to use a slightly older sample. And you also get slightly more accurate data for congenital hypothyroidism if you can do it at 24 to 48 hours of age. So if I had the option, I would go for a slightly later time than at birth. But nevertheless, pragmatically, it can be the most relevant time to do because you get the most compliance. The other time, as mentioned there, is before leaving hospital, or if they're in a village around 48 hours of age. As mentioned, you need different cutoff points because your TSH levels are higher earlier. So if in Sri Lanka we're using cord blood, they'll use a TSH of greater than 40 for those under 48 hours of age and greater than 20 if it's taken after 48 hours of age. And that's because your TSH falls quite precipitously over the first day or two of life. But collection ideally is a little later. Not always possible, but that's when we should be aiming for. Normally in that situation, you need a community nurse or an infrastructure, so a community nurse or a midwife can take the sample. Now, in terms of cutoffs for identification, for direct notification of pediatricians, most screening programs have an upper cutoff level where there's direct referral to a pediatrician, and a lower level where if it's a borderline test, they suggest getting a repeat. However, in a situation where there's resource limitation, I think a lower initial threshold is less relevant. There's more workload. Most of them are normal. And so I would be suggesting, in the first instance at least of looking at a higher cutoff level only. And I understand that in Indonesia, you'll be looking at a TSH level of greater than 20, and that makes an enormous amount of sense to me, because these are almost always true primary congenital hypothyroidism. In resource-limited countries, you need to minimize the number of false positives simply because of the workload involved in trying to follow them up. So I would go for just that high level of greater than 20. Now, it's very important to realize what happens in terms of your TSH surge. So at birth, when the cord is clamped, your TSH rises dramatically up to 40 to 60 in those first 4 hours. And that increases your thyroid hormone levels, and that has really important implications for physiology, and in particular non-shivering thermogenesis, among other things. But it also makes interpretation of TSH quite hard. As you can see there, the TSH levels rise abruptly over the or drop abruptly from birth until 1 day of age, and then slow and go down logarithmically after that. So they're pretty close to the normal range by 1 to 2 weeks out. But if you're looking between 1 to 2 weeks of age, you're looking at a better time to do it than if you're looking at it earlier, which, as you can see, you would need to have a higher threshold. Right, the one other thing I want to touch bases on briefly is preterm babies. This is not going to be a major issue when we start the screening, but you just need to be aware that it has arisen over the last decade. We've found more and more preterm infants have congenital hypothyroidism. We're looking at rates approximately 10 times to 20 times that in the normal population. So an instance of between 1 in 100 and 1 in 200, so really high levels. The TSH elevation does not occur early normally. It occurs later, and it's probably due to immaturity of the axis and delay in that. And when I'm talking about preterm babies, I'm talking about those under 32 weeks or under 30 weeks. So these are quite preterm. But they can often be missed on early guthrie cards. Most of these are utopic glands, and they almost always resolve by 2 years of age. But they often have very high TSH levels of over 100, and they often have very low T4 levels. And so they do need treatment. And it's very important to pick them up because preterm babies already are at risk of neurodevelopmental problems. So we want to try and maximize their outcomes. But at the moment, the key is to identify them and to treat them. And you will likely need to do a later guthrie card if you're doing guthrie cards on preterm babies. And if you're not, you probably need to do thyroid function tests prior to discharge in case you're missing one of these cases. Right, so that's congenital hypothyroidism. What, in terms of laboratory challenges, what do we need to do? Well, we need to get the samples to the lab. That needs batching. You need a reliable transport. That can be couriering, or it can be posting. Posting can be effective, but if you want to get them there faster, a courier is useful, but they obviously cost more. In a place like Indonesia, where you have a massive archipelago of over 1,700 islands, it creates even greater logistical issues. And of course, you've only got 11 laboratories to send these to, so it just increases it enormously. So I have great respect for Dr. Pulungan and the team for setting this up, because this is no small feat to get this organized. As mentioned, using local postal services is fine, but you might find courier services are useful if you've got the resources, as it gives you more flexibility. And of course, there's ongoing issues of cost of the infrastructure, how you're going to do it, how you're going to get the cards analyzed, and how you're going to get the positive sample identified in an acceptable time frame. And this is all about getting your laboratory procedures in order. And this is something that it's useful to get a newborn screening laboratory technician who's done this in the past involved with. Right, once we've got the positive screening test, we then need to get it out to the families. And I can tell you 10 years ago, in many areas that I used to work in the Pacific, in the islands, in the poorer areas, that was incredibly difficult because they just disappeared and you could not find them. Having cell phones has made our lives much easier, and I suspect that is true in Indonesia too. We can contact families much more easily. But keeping a registry of the and addresses of the people who've had newborn screening is really helpful as well. In Indonesia, this is going to require, I suspect, a lot of community resource because of the issues with the islands and the more village-based midwifery that you have. And in particular, the fact that there is no pediatric resource on some of these islands. So you're going to have to try and get these families to centres where they can actually have either repeat sampling or to see a pediatrician and get a therapy initiated. Which brings me to therapy. So the first question I'd like to ask is, can cognitive therapy be normalised? We know that it can be markedly improved over no treatment. But there's a lot of data out there shows, in the past at least, suggesting that the severe forms of congenital hypothyroidism have persistent subtle neurocognitive problems, although normal IQ scores can be obtained in some studies. Now, the factors that have resulted in better outcome are those who have less severe congenital hypothyroidism, the milder dysharmoniogenesis, for instance, we have higher baseline free T4 levels. If you diagnose and treat them earlier in the first couple of weeks of life, definitely improves it as opposed to 1 or 2 months of age. And if you start with a high initial dose, and by that I mean using a loading dose, so you're increasing the thyroid hormone levels up more quickly. I'm just showing 3 of many studies out there just to give you an idea of what we're looking at. So these are three studies in the last 20 years. And you look at the full-scale IQs and you can see that there's consistently in the subjects numbers which are normal, but compared to the controls are 5 to 10 points lower. So there has this big belief that there is an impact of a low thyroid hormone level before birth that you can't get around. I don't actually agree with that. I think there are some issues with a number of these initial studies. Many of them are cross-sectional. The diagnosis was frequently delayed, often more than a month. The initial dosing was often low. They didn't have a loading dose, even in the so-called high-dose studies. And in the few high-dose studies there were, they didn't actually do any blood tests afterwards. They just left them with elevated thyroid hormone levels. And I'll show you data in a second demonstrating that if you have persistent hyperthyroidism, it is probably worse than having hypothyroidism. So high thyroid hormone levels do bad things to the brain, as do low thyroid hormone levels. You do not want either. The other thing that is concerning me is that the control groups were variable. They weren't necessarily applicable to the groups that were the subjects that were being looked at. And they also sometimes included children with other comorbidities. And by definition, these children were going to have lower IQ anyway. So they needed actually excluding. So the question I had is it possible to get normal cognitive function with optimized therapy? And the first question you have there, the second question is, what is optimized therapy? Well, if you look at what the European Society suggests and the American Association of Pediatrics suggest, they recommend, and I would endorse this, a loading dose, 10 to 15 micrograms per kilo per day. I would suggest at the lower end of that than the high end of that, and I'll show you some data suggesting that in a second, so around 10 to 12 micrograms per kilo per day. Just pointing out, and I'll emphasize this again, in the first 2 years of life, a replacement dose of L-thyroxine is between 4 to 5 micrograms per kilo per day. If you have your child on this level, their thyroid function tests are almost always going to be in the normal range without it being too high or too low. You want to aim to have a thyroid hormone level in the upper half of the normal range to avoid transient hypothyroidism. They recommend dose reductions are needed within 1 to 2 weeks because of that loading dose, otherwise you'll develop overactive thyroid or hyperthyroidism. And you need to use the free T4 if you're doing thyroid function tests in the first few weeks. As there's TSH resistance initially, it takes longer for the TSH to fall, and it takes a wee while for the axis to be normalized. So use your free T4 levels rather than the TSH over that first month or two of life. Now, in terms of the monitoring, these are in ideal situations, which is not what most of us have. Okay, so they're suggesting a thyroid test every 2 to 4 weeks after initial treatment has begun, and then every 1 to 2 months for the first 6 months, and every 3 to 4 months between 6 months and 3 years, and after that, every 6 to 12 months from 3 years of age onwards. This is great, but it's not actually something most of us can organize, particularly if you're on a small island with very little in the way of resource. Having said that, what we did in New Zealand was even more intense than that, but that has given us information that we can use so that you don't need to do so many tests. So we were doing tests every week for the first 6 weeks, then monthly for the first 12 months, then 2 monthly in the second year, and 3 monthly thereafter. So we have a lot of data in that first 2 years of life. So what did we find? Well, the first thing we did, I have to point out, we used different loading doses depending on the underlying cause, because when we first started the study, we couldn't get thyroid function tests back early. And so we started the most severe forms, the ones with no thyroid gland, on the highest dose, and the dysharmoniogenesis, which tend to be slightly less severe, on the lower dose. And you can see within the first week that the thyroid functions of all these children were in the normal range. But if you look at the 15 microgram group, they started lowest, and by 1 week they were the highest. And this is the top end of the normal range. And almost half these patients had hyperthyroidism on their free T4 levels. And this is the reason I would not recommend going that high. I would suggest using 10 to 12. There's a range around this, but you have thyroid function in the normal range. Over the next 6 weeks, the level stayed fine, but we actually reduced quite aggressively the thyroid hormone doses downwards. Otherwise, they became hyperthyroid later. And you can see here the TSH levels. They dramatically fall, but they take 2 weeks to get to normal. You'll remember the T4 was normal by a week. The TSH takes an extra week. So that's why I'm saying look at the T4 levels, not the TSH. They tend to lag, okay? And they came down quite nicely after that, irrespective of the loading dose initially used. But after that load, first week, we then started to pull back on doses. So these numbers here reflect lower dose of L-thyroxine. Now, if we look at the first 2 years of life, so the upper table has got the thyroid hormone levels at the top end of this axis, with the red and blue being the normal range for thyroid function, and the TSH is the lower levels, with the red and blue being the higher and lower end of TSH levels. You can see that in general, the TSH was more or less in the normal range. Some of the ones with athyroidosis went a little higher from time to time, but they were generally in the normal range. And you can see that the thyroid hormone levels also in the middle of the normal range. So really where we wanted them to be. The key here is when we look at the maintenance dose, and I've mentioned this to you before, once you get into a maintenance regime, you're finding that you need 4 to 5 micrograms per kilo per day almost consistently throughout this time. And so this is what we should be aiming at. And indeed, we need to get them up fast, up to normal levels, and then we need to back off quickly. Otherwise, we will make them hyperthyroid or have high thyroid hormone levels. We don't want that. We want them to stay in the normal range. So, can an optimized, intensively monitored program result in normal cognitive function? That's a mouthful. The answer is yes. So this is data from a New Zealand study we did a decade ago. We looked at all our children between 4 and 18 years. We made sure they all had normal thyroid function tests when they were assessed, because otherwise they could have abnormal development just because the tests were abnormal at that time. They didn't have any recent illnesses which can impact on test function, and they had no recreational drugs on board, such as alcohol or other inhaled products which can affect cognition. And what we found, and these were sibling controls, so they were genetically similar to this group, and we found there was absolutely no difference in cognition between the two groups. So if you aggressively treat and manage these kids, the congenital hypothyroid subjects were no worse than their siblings. We did a lot more other developmental tests than the ones I showed you, and we found no differences in IQ or motor function or other forms of processing. So I'm not convinced that the purported in utero effects of congenital hypothyroidism and IQ are permanent, and I think they can be largely ameliorated by a prompt diagnosis and normalization of thyroid function. So what about cognitive outcome in subjects treated with less intensive regimes? So what happens, because we're talking about the best of the best, if you've got lots of resources, you're doing lots of things, but what if you can't do that? Well, before you started screening, back in the 1950s, 40s, 50s, 60s, 65%, 2/3 of all congenital hypothyroid subjects had an IQ of less than 85, and 15% were profoundly retarded with IQs less than 15. So awful outcomes. Once we started screening, this is early on, and this were diagnoses that were often late, over a month of age. They had low dose of L-thyroxine used, no loading doses were used, and they did not do much in the way of thyroid function testing. In this era, no child tested had an IQ of less than 75, so that you can improve outcomes dramatically just by starting therapy, even if it's a bit late, even if it's low dose of thyroid hormone, even if you're not doing thyroid tests, you make a difference. So I think it's really important to realize Yes, it's nice to have everything perfect, but getting treatment started is where we want to be. If we can do some testing, if we can make sure the doses are about right, that's useful. But the key is diagnosing them as soon as possible, starting them as soon as possible. Now, I've talked about over-treatment, and we know that in a number of rat studies that have been done, if you over-treat mice pups, you cause abnormal myelination and you have severe developmental delay. It was for quite a long time in Europe, and in America for that matter, and the appropriate approach was to use a big dose of thyroid hormone at birth and just leave them and not even measure them. And if you measure them, you still didn't change the dose. And these children were hyperthyroid for months or years. And so this group, Bonker-Schonking, which really proposed this or supported this approach, looked at 61 patients over a prolonged period of time. And the first two studies at 2 and 6 years, they were saying how great this was, how the development was better in this group. But it changed as they got older. And so what they showed, and I think this is really, really important information for us treating these children, they showed more rapid normalization of TSH, had a higher IQ. Okay, all well and good, so long as you didn't have hyperthyroidism. So you gained 14 IQ points if you rapidly normalize, 7.7 IQ points if you normalized a bit slower, and that's compared to slow normalization. But what happened if you overtreated? Well, if you overtreated, you lost between -18 to -13 IQ points at the age of 11 years compared to the other groups. You had a massive loss in IQ. And if you looked at undertreatment without overtreatment, that resulted in a normal IQ. But if you had overtreatment, you ended up with an IQ that was 15 points lower. The bottom line here is do not overtreat your patients. It is bad, if not worse, for them than overtreatment, okay? You get myelination abnormalities with both under and overtreatment. So the idea here is to try and keep their thyroid function tests in the middle to high end of the normal range. Okay, so finally, what about therapy? In the first 2 to 3 years during brain myelination, I think we first of all should avoid sustained periods of overtreatment whenever possible. Overtreatment is bad. Other studies have also suggested if your TSH levels are frequently above 15, you also have a lower IQ long term. So you do not want to run these patients hypothyroid. So you have this range, and this is where doing thyroid function tests is useful if you've got the capacity to do it. But if you don't, run their thyroid function tests at around 5 micrograms per kilogram per day and measure their body surface area and adjust their dose accordingly. When you first diagnose them, make sure you get their thyroid function test in the normal range rapidly. Do not use a low dose. You want to use a loading dose of L-thyroxine between 10 to 12 micrograms per kilo per day for at least a week and maybe 2 weeks. Then you need to reduce it back for 2 to 3 weeks down to between 5 and 7 micrograms per kilo per day, and then down to 5 micrograms per kilo per day and maintain it thereafter for the next 2 years of life. If possible, get thyroid function tests, get a free T4 and TSH. But and if you can, ideally every month for that first 3 to 6 months, and then 3 monthly. But if you can't, focus on the dose, because that will give you a really good idea of the thyroid function, of the amount of thyroid hormone they need. So what about a suggested approach for resource limited countries? Well, first of all, you need to identify your small group of advocates, and that's been done. And you've got quite a large group of advocates in Indonesia, and I congratulate them on what they've done to date. You need funding. That needs to be long-term, but the cost of congenital hypothyroidism alone are not that expensive. It's more around the infrastructure that costs more. You have to focus initially sometimes on hospital-specific regions until you've worked out how your program is going to work, and then iron out all those small issues before you extend it out further. And as I said, to be practical, start with a small group and then extend it as you're able to. Consider involving outside groups. This is a GPED meeting, but think about CLAN, think about APIS. There's a number of other agencies in the Asia-Pacific region who could potentially help set up or assist in newborn screening. And as I keep saying, have a pragmatic, practical approach to the collection and testing. It'd be great if you got it every few days, but if you can only get it every week or 2 weeks, that's okay. You will make a difference if you can get that diagnosis in the first month of life. If you don't have your own laboratories, which you do in Indonesia, look at external laboratories, but I think that's already set up. You need some basic infrastructure in place, and that's about contacting families, getting them to clinics, starting treatment. And the focus should initially be on the severe end of the spectrum. Look at those TSHs greater than 20 as you're doing. Have only one cutoff point. It depends on the collection time. If it's early in life, you might want to look at it greater than 30 or possibly 40. If it's over 48 hours of age, you might want to look greater than 20. And I'll leave that to your team to make that call. But I think what we want to be looking at first is picking up the severe end of the spectrum and then looking at the less severe once the procedures are in place. I want to stop there. I'd like to acknowledge a number of people, particularly Diane Webster, who's really the mother of newborn screening in New Zealand and has been doing this for 40 to 50 years and has set up screening programs in many places in the world. And I'd like to give her a great applause for what she's done. There are a number of endocrinologists who were fellows when they did this work, Ben Albert, Natasha Heather, and Sarah Matai. Particularly Natasha has also taken on the newborn screening program in New Zealand and Australia, as well as a number of other people who have helped in this research. Thank you again, and I would be very happy to take any questions.
Thank you very much, Professor Hofman, for your enlightening presentation. I'm sure our participants already have burning questions and that would like to ask you and also to Prof. Aman. And we will now invite Professor Aman and Prof. Paul Hofman back to the screen. And also I want to invite Ibu Director, Ibu Maria Sumiwi and Dr. Faizi to because some of questions related to the SHK policy in Indonesia. And this discussion will be delivered in bilingual, in Bahasa and in English. Please, so the question. Yeah. For Profesor Aman Pulungan, apakah hipotiroid bisa deteksi sejak masa kehamilan?
Saya jawab langsung ya.
Ya, silakan.
Ya, karena memang jadi hipotiroid kongenital ini harus dideteksi setelah lahir memang. Jadi makanya namanya itu juga newborn screening. Ya. Jadi tidak ada cara dideteksi pada saat dalam kandungan dan semuanya itu jadi baik penyebab apapun tadi maupun dia yang mau ektopik atau agenesis ataupun misalnya dishormogenesis atau disgenesis, semuanya itu tidak bisa terdeteksi pada saat dalam kandungan. Ya, jadi memang harus lahir dan idealnya itu 48 sampai 72 jam. Ya. Begitu ya, Dr. Faizi ya.
Baik, terima kasih. And then next question for Professor Paul Hofman. Why is Hill trick with filter paper the chosen method for NPS instead of venous TSH? Still mute, Prof.
Thank you. Can you hear me?
Yes.
Excellent. Thank you. The reason that we go with filter paper is that it means that we can get the blood test to a laboratory and it can be delayed. If you're out in the community, venous blood will be unstable. So this gives us a way to get the blood, clotted blood on a filter paper, which is stable at room temperature for many days, if not many years if it's kept at 4 degrees. And so it's actually a very easy way of getting this information or getting the sample to a place where you can do the assessment without the sample deteriorating.
Okay, thank you. Jadi pertimbangannya karena luas dan stabilitas ya ini menyangkut sesuatu yang diselenggarakan secara luas. Next question. kepada Kementerian, sejauh mana aspek legalitas perlindungan yang didapatkan seorang nakes jika setelah proses pengambilan sampel SHK si bayi mengalami efek samping, misal luka serius pada bekas rujukan atau bahkan mengalami sepsis yang diakibatkan proses pengambilan sampel tersebut. Silakan Ibu Dirjen atau Ibu Direktur.
Ya, makasih Dok. Jadi nomor 1 tentang perlindungan ya oleh perlindungan untuk nakes. Nah, di undang-undang yang baru kita bilang bahwa untuk semua hal dispute seperti ini ya, dispute hukum seperti ini yang berkaitan dengan praktek pelayanan medis atau pelayanan kesehatan, maka semuanya nanti penegak hukum harus minta pendapat dulu dari MKDKI. Jadi akan dikasih dulu ke MKDKI gitu ya. Kalau itu dokter. Nah, nanti ada majelis kehormatan disiplin yang untuk tenaga kesehatan. Jadi tidak semuanya akan langsung ditangani oleh penegak hukum. Lalu yang kedua, kita baru saja membentuk pokja ahli untuk newborn screening, dan kita baru saja ada kasus ya, baru ada kasus di Medan ya, di Sumatera Utara, bahwa setelah diambil kok anaknya aspirasi, meninggal sesak gitu. Nah, ini kita akan menurunkan tim ahli dengan tim dari GIKIA, terutama untuk mengetahui kronologi sudah kita dapatkan sebetulnya kronologi. Jadi lalu juga untuk menyampaikan apa sih coincidence tidak selalu sebab akibat gitu ya. Untuk sesuatu yang dalam waktu yang sama itu bukan berarti ini disebabkan oleh itu. Jadi ada tim ahlinya, lalu juga ada peraturan regulasi di undang-undang yang mengatur bahwa ini tidak bisa, yang berkaitan dengan layanan kesehatan tidak bisa diputuskan oleh aparat penegak hukum saja, tapi harus minta pendapat dulu dari majelis kehormatan. Demikian perlindungan hukum yang kita berikan. Makasih, Dok.
Terima kasih.
Can I just add to that? Although I don't understand Indonesian, in New Zealand we look at any side effects, potential side effects. Every year we have a national meeting. We look at the national data, and over the last 15 years there has not been one incident of a side effect of taking blood on these children. So I think if it does occur, it's incredibly rare.
Next question. Next question, please. Untuk Profesor Aman Pulungan, apakah ada hubungan antara kejadian HK pada bayi lahir dari ibu yang hipo atau hipertiroid? Kalau bayi lahir dari ibu hipertiroid, apakah di screening atau langsung cek TSH dan FT4?
Sangat ada berhubungan. Apalagi kalau ibunya hiper atau hipo, ini kita lihat kalau dia misalnya contohnya hiper atau grave disease, tentu dia autoimun, ya, antibodinya ini bisa masuk melalui tali pusat, ini yang pertama. Jadi bayinya bisa hipo atau hiper, ini yang pertama. Yang kedua, kita harus menilai juga apakah ibunya itu pada saat itu dalam keadaan minum obat atau tidak. Tentu kan jadi ada pengaruhnya jadinya. Apakah ibunya minum obat misalnya anti tiroid ataupun hormon tiroid. Nah, pertanyaannya apakah diperiksa langsung FT4 TSH? Tetap saja dia melalui proses newborn screening. Ya. Jadi kita lihat nanti tentu. Nah, kalau dia misalnya ternyata normal, tetapi ibunya ini masih dalam keadaan tetap minum obat dan bayinya dapat ASI, konsultasikanlah ke dokter anak. Ya. Ya. Konsultasikanlah ke dokter anak, ini kan dari GP ya, atau kalau ada endokrin anak. Karena ini jadi detail, ini harus ada beberapa yang kita lihat jadinya. Begitu Dr. Faizi ya. Jadi kalau misalnya ada, dilihat, tetap harus diperiksa. Ya. Kalau dia misalnya ternyata TSH-nya positif, terlepas dari ibunya hiper atau hipo, tetap harus dikonfirmasi. Jadi proses alur newborn screening yang dari pemerintah ini tetap harus dilakukan. Ya. Tetapi kalau misalnya hasilnya toh negatif, tapi ibunya minum obat, baik hiper atau hipo, konsultasikanlah ke dokter anak yang ada di Fasiankes atau dokter endokrin anak kalau ada di kota tersebut. Begitu ya, Dr. Faizi ya?
Terima kasih, Prof. Aman. Jadi tetap diambil sampelnya. Terima kasih. Next question. Untuk kementerian, mengapa pemeriksaan SHK harus dilakukan pengiriman sampel ke tempat rujukan pemeriksaan yang ditunjuk oleh Kemkes dan tidak dilakukan pemeriksaan di sarana rumah sakit sempat saja seperti saat COVID?
Ya, makasih. Makasih. Jadi ini memang kita sudah exercise ya. Sudah exercise kalau kita menaruh alat, kemudian berapa load-nya. Nah, itu di awal kita memang 11 rumah sakit yang ditunjuk oleh Kemenkes. Tapi tentu saja kita akan mengevaluasi terus, apalagi dengan tambahnya load sampel yang akan datang ya, dengan wajibnya pemeriksaan SHK ini pada bayi lahir yang ditanggung oleh BPJS. Itu kan wajib mulai 1 September. Nah, pemeriksaannya juga bisa dilakukan oleh swasta di laboratorium swasta. Tadi kalau kita lihat presentasinya Prof. Aman, kita bisa lihat sebagian besar memang dari rumah sakit rujukan, tapi sebagian juga ada dari layanan swasta ya, lab-lab swasta. Jadi ini kita akan terus mengevaluasi load di 11 rumah sakit ini sudah maksimal atau belum. Lalu nanti kita akan lihat apakah bagaimana kita menambahkan lab atau memetakan kembali lab-lab yang akan kita biayai ya. Demikian Dr. Faizi.
Terima kasih Ibu Maria. Jadi masih ada kemungkinan teman-teman, tidak usah khawatir. Next question dari Dr. Abdul M. Ya. Could you elaborate on screening in premature infant?
Yeah.
Prof. Hofman.
Thank you. This is tricky and probably the next step or 2 or 3 steps down from the initial screening that you want to do on term babies. But you're going to find when you look at your preterm babies, and as I said, you're looking at those who are very preterm, under 30 to 32 weeks, and the ones who are more on intravenous nutrition, they seem to have very high rates of primary congenital hypothyroidism. The reasons behind that remain a little unclear, and we're looking at some of those reasons now. But because they have an immature thyroid axis, they don't often have high TSH levels at 48 hours. It's often at 2 or 3 or 4 weeks of age. And so you will miss this hypothyroidism unless you test later as well. So in most places in the world, they're now doing a test at 48 hours as per normal, but they're doing one around a month, and then they're doing another one before they go home to make sure you pick up these patients, because if they truly have persistent low T4 levels, they are at risk of worsening any neurodevelopmental issues they had because they were born preterm.
Thank you. Jadi kalau di tempat kita yang boleh di peraturan Kemenkes itu kita punya policy tetap diambil, nanti bisa diulang pada umur 2 minggu, itu yang kita lakukan. Thank you. Next question. Untuk kementerian, bagaimana solusi untuk daerah Kalimantan Tengah yang luas daerahnya 3 kali luas Jawa dalam penanganan sampel SHK, di mana hasil pemeriksaan SHK memerlukan waktu yang lama dalam pengiriman dan hasil. Silakan Ibu Maria.
Ya, makasih. Nanti Bu Desi bisa tambahkan ya. Ini sebetulnya tahun ini kita memang sangat memacu supaya SHK itu setidaknya tahun depan, tahun ini kita pengennya 2 juta ya. Tahun depan itu lebih banyak. Nah, karena ada 11 lab pengampu, ini memang jangkauannya memang agak sangat luas ya kalau untuk seluruh Indonesia. Nah, saat ini kita baru saja juga ya mungkin 3 bulan yang lalu ya membentuk tim khusus sebetulnya untuk secara khusus mengikuti persoalan-persoalan yang ada di lapangan supaya nanti kita bisa cepat pecahkan. Nah, tim kerja ini ada di bawahnya Dr. Lovely Desi, ketuanya namanya Dr. Irwan. Nanti mungkin Dr. Irwan ini bisa ditaruh nomor handphonenya di sini, Bu Desi. Kita memang sedang memperluas secepatnya, tapi masalah-masalah yang ada ini nanti kita akan lihat bagaimana mengatasi. Sebetulnya Kalimantan juga punya Labkesmas Regional 4, ada rumah sakit juga. Saat ini Kalimantan kirimnya kemana ya, Bu Desi ya? Kalimantan Tengah nih.
Kalimantan ke Sarjito, Bu.
Kalimantan ke Sarjito. Ya memang ini cukup jauh, tapi memang kalau bisa dinas kesehatannya itu bisa sangat responsif ya. Kan ngumpulin dari puskesmas lalu dikirim. Ya, ini memang proses yang agak panjang. Kita akan terus evaluasi Bapak Ibu untuk lebih cepat ya nantinya, baik evaluasi peletakan lab-labnya maupun hal-hal yang lain termasuk operasional, pengiriman, pooling sampel dan seterusnya. Demikian Dr. Faizi.
Terima kasih. Selanjutnya, next question for Professor Paul. Will a wrongly done procedure, example taken from the mid part of the baby, heel or from vein that's already occluded, affect the acid laboratory result?
No, thank you. That's a really good question. The answer is generally, so long as you're getting blood that goes into the filter paper itself, that's generally enough. And it doesn't matter where you take it from in the heel. Ideally, it's easier. It's better from the heel. It's easier, but you can take it from anywhere. The problem that we tend to find is that there are circles on the filter paper card, and if you don't completely fill those in, you may not have enough blood to either do the test or to repeat the test. So it's really important to completely fill each of the 4 circles so that they can do the tests appropriately. But so long as the blood is going into the card itself and completely filling the circle, there should be no problem.
Oke, jadi tidak masalah asal lubang screen-nya itu penuh ya, tidak ada multi-layer dan sebagainya. Thank you, Prof. Paul. And then we continue to the next report. That next question for Profesor Aman. Bagaimana apabila bayi harus dipulangkan sebelum usia 48-72 jam, apakah bisa di screening? Nah, ini nanti mungkin nanti juga perlu ditanggapi oleh Bu Desi tentang policy Kemenkes. Kalian
ya. Jadi kalau dari kita secara saintifik, kita tetap menganjurkan di atas 48 jam. Tapi karena keadaan yang terjadi di lapangan, itu bayi dipulangkan sering sebelum 48 jam, akhirnya kan keputusan Menteri Kesehatan yang baru setelah 24 jam. Tapi jangan di bawah 24 jam. Ya. Tetapi seperti contoh kasus pertama kali tadi presentasi saya, ketika nilai TSH-nya di atas 20, tetap harus dikonfirmasi. Dan ternyata kan tadi, contoh bayi yang dari Makassar, ternyata kan normal. Ya. Nah, ini kan memang agak tricky jadinya. Tetapi tetap dilakukan. Tetap dilakukan. Nah, ini yang kalau saya rasa, kalau saya pribadi tetap menganggap kalau dia bukan program, kalau toh dia pulang, kalau hasilnya tetap negatif, saya tetap ingin dia memang diperiksa. Walaupun kejadian false negatif jarang ya, seringnya memang false positif pada bayi sebelum 48 jam. Tapi memang keputusan Menteri Kesehatan yang baru itu sudah sudah menjelaskan keadaan seperti ini, tetapi tidak di bawah 48 jam. Tidak di bawah 24 jam ya. Jadi 24 sampai 48 jam masih oke. Sebetulnya tadi kan Prof. Hofman juga mengatakan bahwa ada beberapa keadaan TSH-nya yang harus kita nilai. Tapi kita kan terlalu sulit kalau mengatakan, misalnya kita mengambil cut-off-nya 20, nanti kita buat umur segini, cut-off-nya 40. Wah, itu pada saat program baru jalan akan membuat pusing dan membuat kesulitan jadinya, ya, Dr. Faizi ya. Kalau kita buat beberapa nilai cut-off kan. Jadi untuk saat ini ikuti saja 20 dan tetap di atas 24 jam. Ada petunjuknya dari Kemenkes, boleh. Jadi ikuti saja petunjuk yang dari Kemenkes ya. Begitu Dr. Faizi, mungkin ada tambahan kalau
dari program Kemenkes tentang klaim-klaim ini yang merisaukan teman-teman di daerah.
Jadi nomor 1 kita ikut dari standar yang baik dari para ahli ya, yaitu 48 sampai 72 jam. Nah, sebetulnya kita ada namanya kunjungan neonatal. Jadi meskipun sudah dipulangkan, nanti laporkan ke puskesmas setempat. Karena di puskesmas setempat itu ada standar pelayanan untuk bayi baru lahir, yaitu kunjungan neonatal. Nanti bisa diambil pada saat kunjungan neonatal. Kemudian yang kedua, kita memang baik ya Prof ya. Kita memang baik tuh. Kalau nggak bisa 48 jam, kapan kita bisa ngetesnya? Ya udah, di dalam Permenkes kita sampaikan, ya kalau terpaksa sekali, di bawah 48 jam, tapi jangan di bawah 24 jam, seperti disampaikan Prof. Aman. Tapi sebisa mungkin, kita waktu terbaiknya itu adalah antara 48 sampai 72 jam. Bu Desi silahkan Bu, kalau mau menambahkan.
Ya, makasih Bu Dejen, Dr. Faizi mungkin menambahkan ya. Jadi kalau kita kebijakan tadi sudah disampaikan oleh Bu Dirjen dan Prof. Aman, untuk persalinan yang ditanggung BPJS itu sebenarnya standarnya pemulangan pasien itu adalah minimal 24 jam. Artinya kalau kita berpatokan kepada standar ya, apalagi persalinan di rumah sakit itu kan bukan rata-rata bukan persalinan yang normal ya, ada komplikasi. Nah, otomatis ini akan dipulangkan lebih dari 24 jam. Artinya ini untuk pengambilan sampel itu akan bisa kita dapatkan sebenarnya kalau benar-benar pelayanan itu kita lakukan sesuai dengan standar. Nah, kalau untuk persalinan di puskesmas juga seperti itu minimal 24 jam baru boleh dipulangkan. Dan ini juga bisa kita dapatkan. Kalau sudah pulang, tadi sudah disampaikan oleh Bu Dirjen, bisa dengan kunjungan neonatus, dan itu untuk kunjungan neonatus kita angkanya sudah cukup tinggi. Jadi sudah melebihi 80% dan otomatis ini akan tercover juga untuk pengambilan sampelnya. Mungkin demikian tambahan dari saya. Terima kasih.
Jadi
saya boleh nambah Dr. Faizi?
Silakan Prof.
Tapi ini kan tadi jelas ya, sudah kita bilang, tadi Bu Dirjen juga mengatakan Bu Direktur. Tapi mohon tenaga kesehatan dokter jangan menganggap ini jadi celah memulangkan lebih cepat ya. Jadi peraturan dibuat bukan untuk ini. Perempuan dibuat ini memang karena kalau memang terpaksa. Tapi jangan dibuat ini jadi celah untuk memang membuat supaya jadi tidak dilakukan 48 jam. Jangan ya. Tolong.
Ya. Saya kebetulan membaca peraturan Menteri Kesehatan Republik Indonesia nomor 21 tahun 2001 pasal 19, jadi tentang pelayanan neonatal dan bayi. Ibu dan bayi baru lahir harus dilakukan observasi di fasilitas kesehatan paling sedikit 24 jam setelah persalinan. Jadi tidak boleh ada yang dipulangkan sebelum 24 jam. Itu tadi nabai Prof. Aman. Tapi idealnya tetap 48 sampai 72 jam. Baik, next question. Pada ministry, pada Kemenkes, bila keluarga pasien menolak untuk dilakukan pemeriksaan SHK setelah diberikan konseling, apa yang harus dilakukan nakes? Izin bertanya untuk orang tua tersebut menolak pemeriksaan SHK pada bayinya. Bagaimana dengan pengklaiman BPJS persalinan ibu?
Ini udah ada juga di Permenkesnya. Langsung Bu Desi karena ini detail ya, Dr. Faizi. Silakan Bu Desi.
Iya. Jadi memang sudah disampaikan di dalam Kemenkesnya itu, Dok. Untuk yang menolak ini harus ada informed consent bahwa keluarga pasien menolak. Jadi ini kan nanti kaitannya dengan klaim persalinan ya. Jadi kalau tidak dilakukan pengambilan sampel, otomatis klaim persalinannya tidak akan dibayar. Tetapi untuk kasus yang memang kalau sudah dilakukan konseling, orang tuanya tetap tidak mau, itu harus ada bukti bahwa orang tua itu menolak. Jadi ada informed consent-nya yang harus dilampirkan. Jadi ada tambahan dokumen untuk yang seperti ini. Tapi memang melakukan konseling terlebih dahulu supaya orang tuanya bersedia untuk diambil sampel.
Ya, terima kasih.
Saya boleh nambah, Dr. Faizi?
Silakan, Prof.
Ya, jadi ini penting juga bagi kita nakes. Kita sudah dilindungi oleh keputusan Kemenkes, ya, Permenkes. Kita lakukan konseling, kita edukasi. Harus ada informed consent. Kalau kejadian seperti kasus pertama tadi IQ-nya 37, kita tidak dituntut mereka nanti. Kita udah jelaskan. Ini kan masa depan anaknya. Coba kalau IQ-nya 37, 60, atau 70, kita sudah tawarkan. Jadi ini harus memang kita jelaskan dan kita kasih informed consent. Ya mudah-mudahan kita berdoa anaknya tidak hipotiroid. Tapi kalau ketika anaknya hipotiroid, ya jangan sampai kita disalahkan juga nantinya. Begitu ya, betul ya kan Bu Dirjen, Bu Direktur ya?
Ya, betul Prof. Karena nanti masyarakat akan makin mengerti bahwa ini standar prosedur untuk newborn gitu. Nanti supaya jangan sampai orang tua kok dulu anak saya nggak di screening gitu kan. Padahal kita sudah keluarkan keluarkan bahwa ini standar untuk newborn. Ya.
Oke, pasti ada waktu. Next question. For Professor Paul, how is screening done in sick infant and infant born with LBW or very low birth weight?
Right, another good question. Again, it's probably not the first thing that you'll be doing with your screening, but in your newborn units with sick children, you will still have primary hypothyroidism. Sick euthyroidism, where you get a low T4 and a low TSH, will not be, will still occur, but it will be different to primary hypothyroidism, where you have a very high TSH. And that's going to happen whether your children are sick or well. If you're sick, you won't have a high TSH level because you're sick. So I think the test is still an accurate way and a reliable way of detecting those with hypothyroidism. So it's not a reason to delay the test.
Okay. Next question. So, Prof. Aman, bagaimana bayi di atas 2 minggu yang belum diperiksa screening, maka karena masalah logistik, apakah langsung pemeriksaan konfirmasi? Ini masalah logistik nanti dikomeni oleh Kemenkes. Silakan, Prof. Aman.
Ya, ini tricky dan memang bagus ini pertanyaan kalau saya bilang ya. Jadi secara teknis dan secara saintifik, ya paper itu masih bisa dipakai, oke? Tetapi secara program, ini nanti saya khawatir dia nggak masuk ya. Nanti mungkin Bu Dirjen bisa mengatakan atau Bu Direktur ya. Jadi secara program, ya. Tetapi kalau misalnya memungkinkan, kalau sudah di atas 2 minggu, ya, itu kalau bisa FT4TSH tentu lebih baik. Kalau di rumah sakit itu ada, ya. Dan sebetulnya kan memang ini tricky jadinya, tergantung di atas 2 minggu umur berapa. Tapi kalau di atas 1 bulan bukan newborn screening lagi namanya kan. Nah, jadi ini memang sangat tricky case by case jadinya. Tetapi ketika memang karena masalah sesuatu hal, dia ternyata tidak dapat untuk dilakukan atau dia lupa datang, yang tadi misalnya dia sudah dipulangkan, dia datang ke kita di atas 2 minggu. Nah, kalau misalnya dia mau dimasukkan, secara teori, secara saintifik masih boleh pakai filter paper. Nah, saya nggak tahu secara policy bagaimana ini, mungkin Bu Dirjen bisa membantu atau Bu Direktur, karena keterbatasan mungkin masalah transport atau masalah teknis, dia datang pas misalnya 2 minggu lebih 1 hari, 2 minggu lebih 2 hari, ya. Kita tidak cerita tentu 1 bulan atau 2 bulan, ya. Kalau saya memang secara teknis masih boleh pakai itu, tapi nanti secara policy mungkin Bu Dirjen atau Bu Direktur bisa membantu saya.
Ya, silakan Ibu Direktur atau Bu Dirjen.
Ini memang kalau di aturan kita nggak ada aturannya ini, Prof. Jadi kita aturannya tetap tadi tuh ada batas 14 harinya.
Ya.
Nah, ini kan kasuistik ya. Kasuistik mungkin nanti memang tadi Bu Desi udah taruh nama Ketua Tim Kerja Dr. Irwan. Ini karena kasuistik, teman-teman Dinas Kesehatan tolong kasus-kasus khususnya diinventori. Kesulitan-kesulitannya, supaya nanti kita bahas tuh. Kita bahas, tim ahli juga bisa ikut membahas nanti pada saat kita rapat hari Selasa ya. Jadi hal-hal yang spesifik itu sepertinya perlu tetap kita inventory dan kita diskusikan apakah kita perlu mengeluarkan policy baru atau tidak. Saat ini policy kita ya policy yang kita ngikutin standar yang terbaiknya. Gitu. Karena kalau ini sangat kasuistik ya, Prof ya, Puan.
Saya setuju Bu, tapi jangan kita bolehkan. Karena kalau kita bolehkan, jadi celah lagi jadinya.
Ya, Bu Desi ada tambahan Bu?
Ya, baik, makasih Bu Didian. Jadi memang kita kesepakatannya menaruh angka 2 minggu itu kan supaya tidak tenaga kesehatan di lapangan itu tidak melambat-lambatkan. Karena kan yang kita kejar adalah secepat mungkin dilakukan SHK, begitu usianya 48 jam langsung diambil. Tapi kalau kita naruh sampai 1 bulan, jadi takutnya nanti ditunda-tunda, jadi terlambat untuk pengambilan sampelnya. Tapi memang nanti untuk yang ini kalau untuk pemeriksaan sih masih bisa dilakukan. Cuman memang dari segi nanti pembiayaan mungkin ya yang dari kita ya Bu Dirjen, dari Prof.
Ya. Sebetulnya yang paling penting juga adalah kita ingin mulai terapi secepatnya. Karena kan terapi terbaik itu di bawah sebulan ya, Prof. Aman, nanti saya dikoreksi kalau salah. Terapi paling maksimal itu malah 2 minggu.
2 minggu tapi kalau sebulan ya masih inilah, tapi kalau idealnya 2 minggu.
Ya, kita itu harus memulai terapi di bawah sebulan. Kalau kita periksanya itu di atas 2 minggu, nggak dapat itu untuk hasil terapi terbaiknya. Kenapa kita mepet-mepetin 14 hari itu pun udah sangat toleransinya udah tinggi sebetulnya. Tapi kita tetap 48 sampai 72 jam karena itu window terbaik, tapi juga kita ingin mengejar terapi diberikan sebelum 1 bulan umurnya karena itu untuk hasil terapi terbaik. Itu kenapa kita taruh window-window waktu di dalam aturan-aturan kita. Terima kasih, Dok.
Terima kasih diskusi yang mencerahkan. Due to time constraint, we unfortunately have to end our discussion here. And thank you very much for Professor Paul Hofman, Professor Aman Pulungan, Ibu Dirjen, dan Ibu Direktur. Thank you as well to our participants for their active participation. I'm certain that they have all learned a lot from today's webinar. And that's all from me, today as moderator. And now I hand over back to MC. Karneta.
Baik, terima kasih kepada Dr. Faizi, Bu Dirjen, Dr. Maria Endang, Bu Direktur, Dr. Lovely Daisy, Profesor Aman, dan juga Profesor Paul Hofman atas pemaparan dan diskusinya yang begitu bermanfaat. Atas nama panitia penyelenggara, kami ingin menyampaikan ucapan terima kasih dan penghargaan yang setinggi-tingginya kepada semua pihak yang telah turut mensukseskan webinar kita hari ini. Sebelum menutup acara kita hari ini, saya mohon izin untuk memberikan sedikit perkenalan terkait GPED. Global Pediatric Endocrinology and Diabetes atau GPED adalah organisasi internasional yang bergerak untuk meningkatkan pelayanan anak-anak yang tinggal di negara berpendapatan rendah dan menengah atau LMICs dan memiliki masalah di bidang endokrinologi termasuk diabetes melalui advokasi publik, pendidikan dan pelatihan tenaga kesehatan lokal, kolaborasi klinis dan pengembangan penelitian klinis translasi. Agar tetap up to date dengan kegiatan GPED maupun update di bidang endokrin anak dan diabetes, yuk follow GPED pada media sosial yang tertera pada slide. Selanjutnya Selanjutnya, kepada seluruh peserta yang kami hormati, mohon untuk mengisi form feedback seperti yang tertera pada slide dan telah dikirimkan pada chat Zoom dan chat YouTube. Pada link feedback form yang sama, apabila dokter, Bapak, Ibu merupakan tenaga kesehatan atau pengelola program screening yang secara langsung terlibat dalam proses SHK, kami memiliki survei penelitian singkat terkait pengalaman SHK di lapangan. Mohon kesediaannya untuk mengisi survei singkat tersebut. Sekian yang dapat kami sampaikan. Mewakili seluruh panitia penyelenggara, saya ucapkan terima kasih dan sampai jumpa di webinar selanjutnya.
Makasih Bu Dirjen, makasih Bu Direktur.
Makasih Prof, makasih semua.
Ya,
Makasih
thank you
Dr.
Paul, thank you
Faizi.
JP.
Thank you, guys.
Yeah.
Thank you very much.
Oke.
Well done,
Thank you,
Aman.
Meta. Thank you, Aman.
Well done,
Thanks,
Alina.
Bob.
Ya.
Okay,
Yuk,
thank you.
makasih Dr. Faizi. Terima kasih Arneta ya. Makasih Dr. Agustini. Ya.
Terima kasih untuk semuanya.
Hebat nih sampai selesai masih ini tetap sama ininya ya. Oke. Ya. Pamit ya.
Thank you, Paul. Thank you, JP. Thank you, JP.
Thank you. Thank you.